Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the channel of Standard Medical Notes. So yesterday we have discussed about resistant hypertension and hypertensive crisis, which includes urgency and emergency in detail. We'll continue the next topic which we have not discussed today, that is accelerated hypertension. Let's begin at the name of Almighty. So what is accelerated hypertension? So it is medical emergency with severe BP more than 180 by 120 mmHg and rapidly progressive end organ damage. This makes it differ from the hypertensive emergency. This is also a kind of hypertensive emergency only, but it is kept separately. This is also a kind of hypertensive emergency only, but the difference between this and other hypertensive emergency is there is rapidly progressive end organ damage. So this makes it different from the other hypertension emergencies. So there is rapidly progressive end organ damage, rapidly progressive. So that is accelerated hypertension. So what is the clinical presentation? So if you do fundoscopy, you will have grade 3 or grade 4 retinopathy, nothing but severe eye disease according to the Oxford classification. Okay, or you can have acute kidney injury. So in urine routine you will have proteinuria or hematuria, and you may have oliguria also. Patient may complain of decreased renal output. Okay, so this is one, fundoscopy and urine routine. Or the patient can present with hypertensive encephalopathy, nothing but patient will complain of severe headache with vomitings. So this is hypertensive encephalopathy. So what is the presentation? So the presentation is either, if you do fundoscopy, grade 3 or grade 4 retinopathy, urine routine or creatinine may be increased. So that is proteinuria, hematuria. And the third one is hypertensive encephalopathy. So mainly malignant hypertension means affects brain, eyes and kidneys. Okay. So how do you manage this condition? Controlled reduction of BP, as we have discussed in other hypertensive emergencies, to 25% reduction in 1 hour. Next, 160 by 100 to 110 in 2 to 6 hours. Then normal BP in 1 to 2 days. So this is controlled reduction. Avoid over rapid lowering, because there is a risk of cerebral or myocardial infarction due to shifted autoregulatory curves. What does this mean? So there is something called as autoregulation. When there is increased BP, so the blood vessels which are present in the brain, they will contract in response to increase in the systemic BP, thereby maintaining the intracranial pressure normal. Okay, so that curve is shifted towards the higher side. That means the autoregulation is nothing but it is a protective mechanism in the brain and also in the heart. Okay, so that protective mechanism is working at a higher level now. That protective mechanism is working at a higher, for example, you can say at 160 mm of Hg of systolic BP, that protective mechanism is getting activated. And how it will protect? It will cause vasodilation, vasoconstriction in response to increased BP, and vasodilation in response to decreased BP in the head and in cardiac vessels. So but when the curve is shifted towards the upward side, meaning now it is it will consider 160 as increased BP and less than 160 as decreased BP. So what will happen if you suddenly decrease the BP? So when you bring down the BP, for example, less than 160, so the protective mechanisms will think that BP is going low. So we need to supply more blood to the vital tissues. So they will vasodilate. So that vasodilation, I think, okay, vasodilate or vasoconstriction. So that will cause decreased supplied blood flow to these areas. This decreased blood flow to these vital organs. So that's by that mechanism they cause ischemia. Okay. So when the BP falls, to raise the BP, they will, I said opposite, they will vasoconstrict. Okay, I said opposite, they will vasoconstrict. When the BP increases, they will vasodilate, so that the pressure in the brain and heart remains constant. Okay, so the goal is similar to the other hypertensive emergencies, 20-25%. I said no, like this you should control. So that is about accelerated hypertension. What is the reason for accelerated target organ damage? There is accelerated fibrinoid necrosis of the small vessels. So small vessels are present everywhere. So because of the fibrinoid necrosis, there is necrosis of the small arteries. So the organs are damaged uh, in a at a faster rate. That is the mechanism. So this is a table from McMaster Medicine. So target can differ. So we have discussed all those things in yesterday video. So just have a look at this. So in accelerated, this is a table for treatment of hypertensive emergencies. Malignant hypertension reduced by 20 to 25%. Hypertension encephalopathy 20 to 25%. What is the first choice? Labetalol. I said it, see here most of the times labetalol, okay, labetalol, and again here also you can take labetalol here also, okay, labetalol. So most of the times labetalol, but when there is pulmonary edema, except in pulmonary edema, the choice is nitroglycerin with a loop diuretic, nitroprusside with a loop diuretic. Why? Because it is a beta blocker, no? So it will reduce in acute events. Beta blockers are not used because they will aggravate the heart failure. So here, but in acute coronary event also we can use first choice as labetalol, but there also we can nitroglycerin in cardiac emergencies. Remember, nitroglycerin is the first choice. So in infarction you can use labetalol, but in acute pulmonary edema you can't use. In acute conditions you can't use. Acute cardiac emergencies you can't use. Cardiac emergency in that too. Cardiac pulmonary edema you can't use labetalol. Okay. Okay. So just see at the, so here 20 to 25% reduction, 20 to 25 reduction. Coronary event, the target BP is less than 140 mm Hg. This is the target BP. Again in heart failure also the target BP is less than 140 mm of Hg. Okay. So how you will reduce? You will reduce step by step manner only. But this is an exception, no? In aortic dissection and eclampsia and pre-eclampsia we have discussed. Okay. In aortic dissection, you should bring the SBP to 120 mmHg in 1 hour. And heart rate we have not discussed there. Heart rate you should bring less than 60 beats per minute immediately within 1 hour. Okay. So that's why in aortic dissection, the antihypertensive of choice is beta blocker like Esmolol or propranolol. These are the beta blocker of choice. Esmolol is the number one first choice drug. Okay. You can add nitroglycerin to lower the BP, or you can add Nicardipine also to lower the BP. But you should have a beta blocker along with those drugs. Second choice, again, you can use labetalol here also. Labetalol or metoprolol. So in aortic dissection also you can use labetalol, second choice, or metoprolol also. But the first choice is esmolol and propranolol. Okay. In eclampsia and severe eclampsia or HELP syndrome, hemolysis with elevated liver enzymes. Okay, HELP syndrome. So there it was less than 140. Okay. According to some client it was given 140, but according to McMaster it is less than 160 systolic divided by less than 105 diastolic. Okay. So what you will do? What is the drug of choice? Magnesium sulfate plus labetalol or nicardipine or oral nifedipine, not the capsular form but the tablet form in sustained release form. Okay. And consider immediate delivery because this is the treatment of choice. Cesarean section is the treatment of choice. So the baby itself is causing all these eclampsia or pre-eclampsia events. So you should take out that baby, then you see the patient will improve very good. But I have seen patients who have developed this eclampsia and imminent eclampsia in front of me, and I've treated also till they go to the ICU successfully with the grace of God. The 4 to 5 days after cesarean section, the lady had developed this imminent eclampsia, not preeclampsia, imminent eclampsia. Okay, so that also you should remember. So even after taking out the baby, the patient can develop this eclampsia. Okay. Okay, so that's about the drugs. So labetalol, you remember one thing: labetalol and nicardipine. Okay, and nitroglycerin and beta blocker. So I said no, in hypertensive emergencies, one should always use IV drugs, and in hypertensive urgencies, one should always use oral drugs. In oral drugs, I said not to be used large suddenly. The BP is the drugs which lower the BP suddenly. Okay, labetalol was there, clonidine was there, or captopril was there. All these are short acting. Others are you can use ACE inhibitors also, ARBs also in hypertensive urgencies, and you will lower the drug slowly. Okay, in 1 to 2 days. So other hypertensive drugs which can be used are, so vasodilators you can use like enalapril. This is the IV form. So oral form is enalapril, ACE inhibitor. So That is a prodrug actually. So this is the active form of the drug, enalaprilat. So it can be used, okay, in acute LV failure, and it should be ordered in acute myocardial infarction. You can use phenol-dopam, hydralazine. So this is one important drug which we use. So let us discuss this in detail. So what is the dosage? 5 to 15 milligram per hour IV infusion. Starting dose is 5 milligram per hour. Starting dose is 5 milligram per hour. Then increase every 15 to 30 minutes by 2.5 mg until target BP is achieved. Then decrease to 3 milligram per hour. Okay. So this is the range which you can use, 5 mg to 15 mg milligram per hour. But you should start with 5 milligram per hour, and by every 15 to 20 minutes you should increase the dosage by 2.5 mg per hour till you achieve your target BP. When you have achieved your target BP and the patient is stable now, then you lower the dose to 3 milligram per hour. So that's how you give Nicardipine IV. So it will act within 30 to 40 minutes. So contraindication is liver failure. So you can't give this Nicardipine in patients with, it is a calcium channel blocker. You can't give this in patients with liver failure. You should remember this. So as along with all the other calcium channel blockers, the adverse effects are headache and reflex tachycardia. So special indications in most hypertensive emergencies like Labetalol, you can use this Nicardipine. In most hypertensive emergencies, you can also use Nicardipine apart from Labetalol, except for acute heart failure. Use with caution in patients with coronary ischemia, because I said no coronary steal phenomena. So there is a risk of coronary steal phenomena. Coronary steal phenomena. So to avoid this coronary steal phenomena, we should not use this in acute coronary ischemia and acute heart failure. That means you should not use Nicardipine in patients with cardiac conditions. You can use Labetalol in MI, but not in heart failure, and Nicardipine not in, it cannot be used in MI also and in pulmonary edema also. Okay, so that's about Nicardipine. So in a liver failure patient, you should not use this drug. So common drugs are there, but you should also know where not to use these drugs. So nitroglycerin is also a common drug. Okay, in cardiac conditions we use. So what should be the dosage? The dosage is 5 to 100 microgram per minute as IV infusion. 5 to 5 microgram mcg to 100 mcg per minute it is. Okay, that was per hour Nicardipine. So onset of duration of action will start in 2 to 5 minutes or 5 to 10 minutes. Okay. So what can be the side effects? You remember nitrates. Okay. One important side effect is methemoglobinemia. Okay. Nitrates. Okay. What is the drug of choice to reverse this? To reverse this methemoglobinemia caused by nitrates. So it is IV methylene blue actually. Methylene blue. Dye. Methylene blue is the drug of choice for this drug-induced methemoglobinemia. Drug-induced methemoglobinemia. Okay, headache, because it is a vasodilator, that's why it's causing headache. Vomiting, a development of tolerance with prolonged use. That's why this is one important thing. So if you use IV nitrates for a long time, patient and also oral nitrate also. That's why there should be a nitrate-free time, so that the patient shouldn't develop this tolerance. This is also seen with oral drugs also. Okay, that's why nowadays newer agents are coming, like they are designing the drug, the capsule like this. The drug is there for 4 hours and not there for 4 hours, and again the drug is there for 4 hours and not there for 4 hours. So like that they are designing. And whenever you are dosing the patient with nitrates, don't keep it, don't dose like the nitrates are present for 24 hours in the patient's body. At least some 4 to 8 hours gap should be there. So nitrate free gap should be there. Otherwise the patient will develop tolerance to this nitrates. Okay. So most important thing is ischemia and heart failure. These are the drug of choice. Okay. Sodium nitroprusside is not available. We don't use it. Hydralazine is not available. So hydralazine is coming now, but hydralazine you should use because it causes what do you call fluid retention and tachycardia. So hydralazine and minoxidil we have studied should only be used with beta blocker and diuretics. So beta blockers now. So most commonly which is used, we will discuss first that. So Labetalol we will discuss. So Nicardipine we have discussed. Now Labetalol. Okay. So Labetalol is the most commonly used drug. So the dosage is 20 to 80 mg IV bolus. So you can give up from 20 to 80 mg bolus dose of this one. So one vial contains maximum 20 mg. Okay. Every 10 minutes you can repeat, or this is bolus dose. Okay. Or you can use it as infusion in the dosage of 0.5 to 2 mg per minute as infusion. 0.5 to 2 mg per minute is Labetalol. Just to revise important drugs. Okay. 0.5 to 2 mg per minute is Labetalol. 5 microgram to 100 microgram is nitrates. Okay. And 5 to 15 milligram per hour, this is also per minute, okay, is Nicardipine. Okay, this is as infusion. Okay, 0.5 to 2 milligram per minute. Okay, milligram per minute. Okay, so it will act within 5 to 10 minutes. Okay, you should avoid in because it is a beta blocker, you should avoid in blocks and acute heart failure in patients with asthma. That's an important point. In patients with bradycardia. Okay, so what are the side effects? Vomiting, scalp tingling sensation in the scalp, burning sensation in the throat, dizziness, AV block. These are the side effects. In most hypertensive emergencies, you can use this except in patients with acute heart failure. Nicardipine, you cannot use in heart failure also and also in MI also. Beta blocker only in heart failure, you can't use this. Aortic dissection also a second choice, you can use. First choice is Esmolol. We will come to that. So aortic dissection, the number one choice is Esmolol. Along with that, you can add some like hydralazine, okay, Nicardipine to that. So 50 to 100 microgram per kg IV bolus can be given. 500 to 1000 microgram per kg IV bolus followed by 50 to 100 microgram per kg per minute as IV infusion. Bolus may be repeated after 5 minutes or infusion rate increased to maximum 300 micrograms per minute. Act in 1 to 2 minutes. So avoid in blocks or acute heart failure, asthma, bradycardia, nausea, IV block. So you mainly used in aortic dissection. Okay, and perioperative emergencies. Remember this. Mainly it is used in aortic dissection. Esmolol. What is the dosage of Esmolol? What is the dosage of Esmolol? So dosage of Esmolol, you can give bolus dosage is bolus for Labetalol is 20 to 80 mg. Okay, you can repeat in 20 mg. Okay, increments up to 300 mg bolus you can give this Labetalol. Okay, bolus of Esmolol is 500 microgram to 1000 microgram IV bolus. Okay, then followed by 50 microgram to 100 microgram IV infusion per minute. Yes, per kg per minute, it is per kg per minute, and you can increase the dose up to 300 microgram per kg per minute. Okay, or if you are giving it as bolus, you can repeat again the bolus in like this 500 microgram to 1 milligram, nothing but 1000 microgram in after 5 minutes. You can, if you're doing, you can give by two methods, either by repeating bolus doses or giving the drug as a continuous infusion. Infusion is safer. Infusion is always safer. Okay, that's why infusion is preferred. So that's about Esmolol. Three important drugs: Labetalol, Nicardipine, Esmolol. Okay, Phentolamine is important, uses pheochromocytoma. Okay, so 5 to 15 mg IV is given. Okay, what is the side effect? Tachycardia, headache, flushing. So pheochromocytoma is used. Urapidil is one more drug, so it can be used as 12.5 to 25 mg as a bolus injection and infusion also. So in most hypertensive emergency, this is an emerging drug, Urapidil. Remember this, Urapidil is an adrenergic inhibitor. Okay, so the dose is 12.5 mg to 25 mg bolus injection. Okay, side effects: dizziness, headache, nausea, vomiting, dyspnea, palpitation, tachycardia, bradycardia. Side effects are very much. Okay, so that's why it's a second line drug in most hypertensive emergencies. So not to forget the first liners. Not to forget the first. Who are the first liners in emergencies? Labetalol. Second, Nicardipine. Third, nitrates in cardiac conditions. Fourth, Esmolol in aortic dissection. So these are the first liner drugs in hypertensive emergencies. Okay. That's about all. Now we will see some special context of hypertension. Okay. So when you see hypertension in the elderly, So the prevalence of hypertension in the elderly is more than 70%, those who are aging more than 60 years of age. Stroke risk reduction even in very old is the key, is the main goal, like more than 80 years of age. Risk of orthostatic hypotension falls. This is a important thing which we should remember while treating hypertension in patients who are aging more than 60 to 80 years of age. But the stroke risk is very much in these patients. We need to treat also, but we need to keep this in mind that they develop falls and orthostatic hypotension. That's why the goal is not the target BP is not too tight in these patients. In patients with more than 60 to 80 years of age, the targets are relaxed. How much? If you can achieve less than 140 by 90, well and good. Or if you can't achieve, then less than 150 by 90 is also okay. Less than 140 by 90, if the patient is getting repeated falls, then keep the BP at 140, 140 to 150. Try to keep it within less than 140. Okay, in patients who are aging more than 60 to 80 years of age. What is the target? 140 to 150 is the less than 140 to 150 is the target. So drugs preferred: thiazide diuretics and calcium channel blockers, especially effective for isolated hypertension. Okay. Now, hypertension in diabetes mellitus. I will take this up. Hypertension in diabetic cluster. This is known as metabolic syndrome. Okay. There is a high risk of renal and cardiovascular complications in patients with diabetes mellitus. The target is strict in diabetes mellitus. The target is, I said no, comorbidities, you should use the 130 by 80 guideline. Without comorbidities, you can use 140 by 80. Elderly age, relax the target 140. Not achievable, keep it 150. Okay. Okay. So what are the drugs? AC inhibitors or ARBs are the first line for renal protection. And if you are using what do you call this one, anti-diabetic drugs, then SGLT2 inhibitors and GLP-1 agonists have cardiorenal benefits. That's why now the triple combinations are coming. Previously, just only metformin was the first drug of choice, and then you used to add glimepiride. Now the thing is not like that. Now the first line, even I am also doing the same thing, and many guidelines are recommending that metformin plus GLP-1 agonist. If not possible GLP agonist, then you can give a DPP4 inhibitor and SGLT2 inhibitor. This is the combination which is preferred now. First line combination, triple combination for patients who are having diabetes mellitus. Okay. Example: dapagliflozin plus vildagliptin or sitagliptin you can take, plus metformin. Like this, the triple combination has become the first line drug in diabetes now. This has advantage. It will reduce the HbA1c by 2 to 3%. This itself. Okay. And there is no risk of hypoglycemia also, unless you add some sulfonylureas or give insulin to these patients. Hypertension in pregnancy. So when you call pregnancy induced, also known as pregnancy induced hypertension. Definition: new onset hypertension of more than 140 by 90 after 20 weeks gestation. 20 weeks of gestation. So if you divide by 4, that means 4. So after 5 months of amenorrhea. 5 months of amenorrhea. Okay. Fifth age, that is in the second trimester of pregnancy. That means after fifth month, in the fifth month you can consider. Okay. So 5 months of amenorrhea, patient is now having BP. Okay. Then that is known as pregnancy induced hypertension. Now, plus if the patient has proteinuria, okay, or other organ dysfunction like AKI or liver damage or neurological complications, kidney complications, liver complications, or neurological complications, then it is known as eclampsia. Okay, then it is known as eclampsia. So the thing which is pointing towards eclampsia is this proteinuria and edema. If the patient is having BP plus proteinuria in urine plus edema, then this is a pointing towards imminent eclampsia. That means patient is going to develop eclampsia. Okay, most common thing, patient will develop seizures. Okay, but they can also have a HELP syndrome, elevated liver enzyme hemolysis. Okay, and elevated phosphate. And this one also, acute kidney injury, loss of urine output. Okay, so that thing you should remember. What is pre-eclampsia, imminent eclampsia, and eclampsia? Pre-eclampsia is just raised PP. Imminent eclampsia is you are getting protein. Eclampsia is there is target organ damage. That's the thing. Okay. The preferred oral drugs are, this is not given. Okay. Labetalol is given. Nifedipine is not given. Nifedipine can be given in tablet form, slow release, or nowadays many gynecologists and cardiologists they prefer Nicardipine instead of Nifedipine. Okay, in slow release form, Labetalol and Nicardipine. These are contraindicated because they are teratogenic. Their renal complications can be seen in the baby. How you will prevent? So the patient had history before of pregnancy induced hypertension in her previous delivery. So low dose aspirin of 150 mg from 75 to 150 mg before 16 weeks in high risk women reduces the risk of preeclampsia. So you should end this aspirin. So when you diagnose second pregnancy, so first pregnancy the patient had a pregnancy induced hypertension or eclampsia like thing. So now when she is UPT, urinary pregnancy test is positive, you start aspirin in the dose of 75 to 150 mg in these patients. Till what month? Till 4 months you should give that aspirin. That reduces the risk of this eclampsia in these patients. Okay. Okay, that's all about hypertension in pregnancy. We are concluding now hypertension, and I will close this. So, what are the advanced consulted insights? Okay, what is the advanced in which we are consulted insights? That thing is the reinforcement loop. What is that thing? The clinician must recognize that hypertension is a self-perpetuating condition. High pressure causes vascular remodeling and arterial stiffness, which in turn elevates SBP and causes further pressure-related damage. This vicious circle is why early intervention in the elevated range is increasingly advocated. Okay, so this is known as reinforcement loop, which I have discussed in pathophysiology only. Okay, so kidney causes vascular damage. Vascular damage causes hypertension causes vascular damage. Vascular damage causes hypertension. Again, hypertension will cause vascular damage, and again, vascular damage causes hypertension. This is the reinforcement loop. That's why treating the BP is very important. Okay, otherwise there are very much mortality and morbidity in these patients. Furthermore, the insulin resistance phenotype often precedes the development of overt hypertension by years. Visceral adiposity, this is important point. So patient has not developed hypertension, but he will develop the insulin resistance first, then they will develop hypertension. So visceral adiposity, waist circumference of more than 102 in men or more than 88 centimeter in women, is a more powerful predictor of hemodynamic instability than total body mass index. So waist circumference is a good predictor than when compared to BMI. So 102 visceral adiposity, abdominal circumference you should measure. 102 centimeter in men and 88 centimeter in women. Okay, so these patients have insulin resistance. Okay, in these patients, the metabolic milieu characterized by hyperinsulinemia, high triglycerides, low LDL magnifies the vascular damage caused by the pressure itself. Okay, that means insulin resistance gives a clue that this patient will develop hypertension in some months or years. Okay, or some days also. So the fatty patients, and that too, the visceral fat, this one, abdominal fat, that is more dangerous. Okay, future directions and emerging paradigms. The 2024 ESC guidelines, European Society guidelines, introduce a paradigm shift toward as low as reasonable achievable targets for SBP, 122 to 130 for most patients, provided the treatment is tolerated. This is supported by the SPRINT trial, which demonstrated a 25% reduction in cardiovascular events and mortality with intensive control compared to standard targets. Innovations in patient-centered care include the use of digital tools and telehealth to improve adherence and the integration of motivation entering into the consultation. The systematic screening for primary aldosteronism in all confirmed hypertensive adults is another emerging recommendation. This is also an important point. Acknowledging that this secondary cause is much more prevalent than previously suspected and often requires targeted mineralocorticoids receptor antagonism. Okay, so this is the most common cause of secondary hypertension. That's why primary aldosteronism should be excluded in all patients who are newly diagnosed with hypertension. Okay, that is the stress which the guidelines are giving. And one more stress: keep the BP less than 130. This is the as long as the patient tolerates the BP. That is one more thing these guidelines are stressing. Okay, keep the BP less than 130 as long as the patient tolerates. And one more thing is, always rule out this one aldosteronism in all patients who are newly diagnosed with hypertension. So now the last one, this is the summary of whole topic of hypertension which we have studied till now. This final structured recommendations. Okay. So what you will do, you will do a diagnosis either by ABPM, ambulatory BP monitoring, or HBPM, home BP monitoring for all cases except gate 3. Okay. Or office BP also. One more thing is office BP. Who can't do these two? Okay. And the cutoff for these two are different. But this is possible only when the SBP is 180 and DBP is less than 110. If the SBP and DBP are cutoffs are more than this, uh, or if there is target organ damage at the first visit, then you will start the drugs, antihypertensive drugs there itself at the first visit only. Okay. Then what is the workup? So first we will assess this, rule out the secondary causes like renal cause, endocrine cause, metabolic comorbidities which are associated with this hypertension. And one more thing is, you should assess target organ damage in these patients. So investigations are focused to rule out target organ damage and secondary cause, organ damage and secondary cause. So first you will diagnose, then you do investigations, history, physical examination, investigation, very well and very deeply discussed in previous video. Then what you will do, the third point is, then you will quantify 10-year cardiovascular risk for that patient by using Framingham score or quad 3 score, or the latest one is the prevent score. Okay, prevent score. These are the scores, score 2 or ASV CVD equations. So if the cardiovascular risk is more than 10%, then that patient should be considered high risk, and the threshold will come to 130. If that patient is having more than 130, you should give that, you should prescribe that patient antihypertensive drug. Okay. Therapy. What is the therapy? So initiate single pill therapy, AC inhibitor, ARB plus CCB diuretic, A plus C or D. For most stage 2 patients. What is stage 2 patients is nothing but DBP more than 140 by 90. This is stage 2, 140 to 160. Okay. 100. Okay. For all stage 2 patients, this is enough. Dual drug therapy. Target BP is in most patients is 130 by 80, but the patient should tolerate that. Adult groups, the targets are relaxed. Okay. For most patients, is less than 130 by 80. How you will follow up? Reevaluate the patient 15 to 13 days. I said in 15 days, you will get 90% of the activity of the drugs. In 1 month, you will get 100% activity of the drugs. And then every 3 months, you should say the patient to have a visit to check the BP. And every yearly, you should have annual screening for target organ damage, which includes urinary albumin creatinine ratio, and ECG you should do, and also fundoscopy. One more thing is there. So you should do these things: fundoscopy, ECG, and ACR. When do you refer resistant hypertension which is not responding, suspected secondary causes, and for specialized interventions like renal degeneration in uncontrolled cases, you should refer. So that is the whole summary of the topic of hypertension. So by this we finish the topic of hypertension. So I will I will come with the next vascular topic in the next video. Till now, if you have listened, I have learned so much. I hope you have also learned so much, and we will deal and we will discuss. We will come with some new topic in the coming video. Thank you.